This is my personal mental model. I want to be very clear that this is not something I'm recommending you follow, but this is how I think through it. So, is it a squeeze issue is really the first question, because that's something I can eyeball and see, right? If a patient has poor ejection fraction, very poor squeeze of that left ventricle, there's a good chance that that tachycardia is compensatory. So if there is a reduction in LV ejection, then I'm going to consider inotropic agents and fix the underlying issue, right? Maybe they need to get to a cath lab. Now, if it's not, if I see that mitral valve is slapping the septum and it looks pretty good, then I ask, can the RV tolerate a 250 cc bolus? Basically, can the RV tolerate a little bit of fluid? And so I'm looking for like that absence of RV strain. And so if it doesn't look like the RV can handle it, right? If I see that RV is huge and it looks like that patient with a pulmonary embolism where you have an underfilled LV and a big, dilated out RV, then I need to consider inotropy to try to improve the inotropy for the RV. And then I need to maybe consider like pulmonary vasodilators, figure out why is this pressure building up in the right ventricle and not getting that fluid to the left ventricle. Now, if the RV can tolerate it, and I see that, my IVC is nice and small, I got a good 50% collapsibility, then I want to know if I give some fluid, does the tachycardia improve? It's always safe when you can see that the LV looks like it could use some fluid, the RV looks like it can pass it over to the LV. It's always safe to try to give a little bit of fluid and see how they respond to that. And so if they do, and the heart rate starts to come down, then you rebolus. Obviously, I'm looking for like B lines and stuff like that as well. However, if it doesn't change with fluid, then follow your guidelines, but this is where you may consider some rate control. But before you get to this area, before you get to rate control, you're ruling out a squeezing issue, right? You're trying to rule out an actual filling issue because of volume, relative or absolute reduction in volume. And then you may have to give rate control. However, I would say the amount of times you actually need to give rate control are very, very few. I think we overestimate the benefit of rate control. And so there's a lot of times the patient has every reason to be tachycardic, and we just get fixated on something like the term RVR. Right now it's faster than 100, so it feels like you have to do something about it.